Welcome to the Golden Hour, the podcast community where moms and moms-to-be hear stories from other mothers and top experts in the pregnancy and postpartum care field. You can visit goldenhour.fm for more information, resources, and all other episodes. You can also find us at goldenhour.fm on Instagram for comments and questions. Hello, everyone, and welcome to yet another episode of The Golden Hour. I'm your host, Dr. O, and I am joined by Eileen. Eileen Johnson is originally from Toronto, Ontario, Canada, and transplanted to Florida and then the Los Angeles area. She attended University of Florida for her undergraduate degree and later completed her Doctor of Physical Therapy degree at Nova Southeastern University in Fort Lauderdale, Florida. She has been a pelvic health specialist for the past 14 years and is currently working at the University of Southern California as an associate professor of clinical physical therapy and a women's health physical therapy residency director. Outside of work, she enjoys spending time cooking Filipino food for her family, tending her garden with her husband, baking with her daughters, 5 and 7, reffing their soccer games, and cheering them on at dance. Welcome, Eileen.
Thank you. I don't mean to interrupt. I don't know if I typed the wrong thing, but I'm only assistant professor. I think you said associate.
Oh, yeah. That's really funny. That's great.
I'm sorry.
This is you being so modest. Yeah, you typed associate professor.
Oh my gosh.
You know, as someone who's not in academics, I never even know the difference between associate and assistant. But either way, I always love reading these blurbs because either way, I'm always impressed with the people I get the honor of interviewing. So I'm still impressed by you.
I must have been wishful thinking, so I had to correct. Yeah, I was like, let me make sure I'm correct with my.
Is the order? Is it assistant and then associate? Is that the next level?
Yes, the next level.
Okay.
Yes.
Well, you're on your way to the next level. We all know it. So yes, okay. You are the assistant.
Manifesting.
Assistant professor, but we're manifesting the associate professorship. Thank you for your humility. Well, this sets the tone quite well because the way that you and I got connected is my sister actually worked with you in the pelvic reconstruction department at USC.
Mm-hmm.
And when I was talking with her and talking to her about even the inception of this podcast and all the things I think are so important for women, not only in pregnancy, but postpartum, it's that pelvic floor. And so I was asking her, advice of a pelvic floor specialist, and you were the first person that she mentioned. And so I'm so happy to finally get to interview her on this podcast.
Yeah, thank you so much. I loved your sister when I got to work with her and missed her a lot, honestly, because she was great. But I'm so glad she connected us. So thank you. Thanks for inviting me.
Yeah. Oh, of course. And I am so grateful because over the next hour or so, you're going to share the wealth of knowledge that you know about the pelvic floor. For me as an OB, one of the many reasons why I create this podcast is because I just want not only to create a sense of community, but I want to give patients the information that they deserve, the information that they really want to feel healthy in their bodies, to feel empowered by the changes that the bodies are inevitably going to go through in pregnancy and postpartum, and not make it feel like such a scary kind of formidable obstacle. And so before we kind of do a deep dive about like the pelvic floor and different ways that pelvic PTs help patients, I'd love to hear about your journey. What made you decide to become a pelvic health specialist?
So my journey was kind of interesting. There's so many different areas of physical therapy that people can specialize in. And so there's like orthopedics is one that everyone knows about. Sports is a popular one. And when I entered PT school, I was really wanting to do anything neuro specific to spinal cord injury, and catastrophic injuries. So like TBI. And that was my goal for to get out of PT school and to do that kind of work. My third year, when we have our full-time rotations, I requested a neuro rotation, and I got a mix of pelvic and neuro. And I kind of fell in love with the pelvic. So it was a really fortuitous placement, because I would have never known that I would be so fulfilled doing pelvic health. And then from there, it just grew. So it was really lucky that I got a rotation in pelvic health and learned just how impactful that kind of practice could be.
Yeah. I mean, I truly believe in serendipity. I myself reflect on my journey to become an OBGYN, and my whole life, like if you ask my parents or my sister, my whole life, I'd always said, I'm going to be a pediatrician. I'm going to be a pediatrician. And I still
Ah,
remember when my earlier rotations in medical school, I was paired with a family practice clinician. And I was telling him about my interest in medicine and how I thought those interests meant that I was going to be a pediatrician. And he was like, you sound like you want to be an OB. And I was like, an OB? He's like, yeah, an OBGYN. I was like, and like that one conversation, I need to find him one day and give him credit
yeah.
for like literally steering my life. But that one serendipitous conversation like totally changed my path. So I love that
Hmm.
your rotation just happened to give you exposure to the pelvic floor, and here we are now.
Yeah. Yeah.
And so thinking about pregnancy and postpartum, why is pelvic floor health so important in pregnancy and postpartum?
Well, like you mentioned earlier, the body goes through so many changes, both physically, physiologically, mentally. And I feel like there's so much that we can offer conservatively that, in pregnancy, some resources or some interventions are limited for pain, for instance. So
Mm,
pain medications, may not be the most appropriate for everyone or the level of pain that they may have. So teaching them and like you said, empowering them with tools that can help them get through pregnancy. Not only that, like restore their function, reduce pain, and then prepare them for the birth, for delivery, whether it's cesarean birth or vaginal birth, and recovery, help hasten the recovery. Um, it's so important. I feel in women's health already, we're just so underserved. Honestly,
yeah,
there's
that's
definitely
true.
a care that could be provided to everyone that's lacking. And with pelvic floor physical therapy, this kind of encompasses the whole spectrum of perinatal care,
Mm,
and other populations, of course. But in regards to women's health, yeah, we can help them both preparing to get pregnant. So we see patients who can't have intercourse because they have dyspareunia
mm,
and they want to have, trying to have family planning, but that's a big challenge. So I've helped patients during that phase. And then upon getting pregnant, helping them throughout their whole pregnancy in regards to their mobility, their function, falls risk. It increases tremendously during pregnancy as well. I think up to 3 times
mm.
a likelihood to fall during pregnancy. And then teaching them ways to improve their pelvic floor muscle awareness, coordination that could possibly not only help with any incontinence that they have or discomfort, prolapse symptoms, but even teaching them how to coordinate, how to breathe, how to push properly in order
Yeah,
to deliver without necessarily straining too much. And then, of course, helping with all the postpartum
yeah,
recovery. I feel like we have
yeah.
lots of tools and can collaborate with our the team to really help our patients.
Yeah, I believe so. I always there are many people that are part of the big healthcare team that has the honor of caring for women, especially through pregnancy and postpartum. But I always give a shout out to my pelvic PTs. Any patient who sees me
Oh,
postpartum, like
yay.
pelvic physical therapists are my favorite, and all patients should really see you guys postpartum. And we'll do a deep dive as this episode continues on about the ways that you help patients pre-pregnancy, in pregnancy, and
Mm-hmm.
postpartum. What would you say are some of the most common issues that women experience with their pelvic floor in pregnancy and postpartum? What are the most common reasons why you see patients?
So in general, I see a lot of patients for pelvic girdle pain. So pelvic girdle pain is anything that is really defined as any pain either along the anterior pelvis, the hip, the SI joint. So that includes like the pubic bone or even the sacrum, the coccyx, and that lumbosacral region. So I see a lot of that. Oftentimes patients will come in because they're starting to have pain with like bed mobility. And so they get up, they're noticing it every time they get up and roll out of bed at night. They're getting this, anterior, posterior pelvic pain. And it can be very debilitating and then it can progress as the
Mm,
pregnancy goes on. We see a lot of ligament pain. So same concept with like the support system and trying to improve their posture, improve their support of their abdominal pelvic support and stability, and then teaching them ergonomics of how to move and maybe avoid straining, and maybe ease pain so that they feel like they can continue doing all the things that they want to do. And then in general, pelvic floor dysfunctions, stress incontinence during pregnancy, and pelvic organ prolapse as well. And there's a little bit of constipation or evacuation dysfunction that we'll see as well.
Yeah, that's a good summary. And I find that, it's so humbling. I always say this. One, it's humbling to be a human caring for other humans, but it's humbling to be human in that we are always in transition. We are always evolving. Our bodies are always changing, whether it's how our bodies change with age. And I'm sure as part of your women's health physical therapy, you care for my older patients, right, who are going through issues with like prolapse, et cetera. But even your body, when you're in your reproductive age, when you're going from someone prior to pregnancy to in pregnancy and postpartum, physically feeling your body change can sometimes feel alarming. And I find that a lot of patients want to go into pregnancy being empowered. And I love that. And so what can someone do, or what would you recommend someone would do if they wanted to kind of, prepare their body for pregnancy? I'm using quotes because, there's so many ways to emotionally and socially prepare in terms of connecting with your community. But in terms of like preparing their pelvic floor or their pelvic physical health, what are some things that you would recommend pre-pregnancy to do?
Yeah, I mean, coming in during pregnancy, even if they're just beginning to start to feel the changes in their body, we can do a lot of things just by looking at posture and teaching them how to maintain like a nice neutral spine position, because oftentimes with pregnancy, with the change in center of gravity, that can lend to increased lordosis, and then that can increase more low back pain and any kind of pelvic girdle pelvic obliquity that can translate to pain with walking and transitional movement. So I think even just starting with education, patient education of when you are standing, when you're walking, when you're moving, this is how we want you to maintain your pelvis, or these are the muscles we want you to use to support your pelvis. I think there's, the classic, when I'm pregnant, maybe I start to waddle, but you don't have to waddle. We want to really promote more of a normalized gait pattern as much as they can. Of course, there's going to be maybe a need for a wider base of support to maintain balance, but there doesn't have to be as much of like a Trendelenburg or like a waddle side to side if they have strong hips, if we can strengthen those muscles. Yeah. So I think there's even preventative in the beginning, teaching them and educating them on these are the muscle groups you want to have strong to maintain that posture and to maintain your mobility and support. So I think that's the first start of the education we can provide, and educating them on things that might later change with pelvic floor as the baby grows. So there's more demand on the pelvic floor. So teaching them how to meet that demand by training their muscles, whether it's like endurance or if they're having more stress incontinence, teaching them how to anticipate those coughs, sneezes, or aggravating things that aggravate stress incontinence, to know when to engage their pelvic floor. That can be really good preventative care.
Yeah. We're all about preventative care in healthcare. And I love that, what you're suggesting is like even early on in pregnancy, even before you feel symptomatic, it's worthwhile to go to your friendly neighborhood pelvic PT and get some kind of coaching about mobility and posturing. You're using a lot of great medical terms, but I also want to acknowledge that our audience is probably widely non-medical people. So can you just explain, I think some terminology that you've used that I don't think that people will know is you referred to anterior, posterior, you said lordosis, and you also said obliquity. Do you mind going back and kind of defining those terms, and going forward, we can definitely try to utilize like kind of more common terminology.
Yes. Thank you so much for reminding me. Yes, definitely. I want to make it so everyone understands. Yes. So there's a couple ways we describe posture. And so lordosis is that posturing where we have a little more sway and arch in our low back. A simple way we describe it, which is everyone gets, but it's an exaggeration, but it's like the Donald Duck posture. So we have Donald Duck, and Donald Duck has a little more lordosis, which is that sway back versus I'm going to age myself versus like a Steve Urkel. Steve Urkel is like the opposite. So Steve Urkel is more the posterior tilt. But so we have Donald Duck type is more of that increased curve of the low back. And then obliquities, really, when I say that, I refer to any kind of lack of symmetry in the way they're walking or the way their pelvis is moving. Sometimes one side will drop. I think I mentioned like Trendelenburg. So one hip will drop because there's weakness in the opposite glute. So there can be a little bit more of a waddle type movement or walking pattern. And that's sometimes most are often due to weakness in certain muscle groups, especially the glutes.
Okay.
Yes.
Thank you.
Thank you.
Because I'm not going to lie, having those definitions are really helpful for me too, right? Because even as an obstetrician gynecologist, I'm not a physical therapist, so I don't even usually reference those terms. But now I have this image of, and I will age myself too. Steve Urkel was the best. That was what Family Matters was the best show ever. So I definitely now will have an image of like Steve Urkel versus Donald Duck, and like that is that's the perfect way to capture that different type of posturing. So thank you.
You're welcome.
Things that I think about and things I'm hearing from you are, again, early in pregnancy, even before having symptoms, definitely reasonable to meet with a physical therapist and kind of learn from a professional like you, the different things that a patient can do to strengthen and prepare their bodies for the remainder of pregnancy and beyond. But I also want to recognize that not all patients are going to have access to physical therapists, either locally or even virtually, whether it's because of financial means, insurance coverage, or just location based. What are exercises that people can do at home on their own? Again, either prior to the start of pregnancy, but early in pregnancy to strengthen their hip muscles, to help with their posture, all the things that you would be able to do with them in a clinic session.
Yeah, absolutely. It's pelvic health is almost like a luxury to get, and having access to care is limited for sure. So a lot of times I tell patients, like, if you can start on number one, a walking program, we go by ACOG's guideline and American Heart Association guideline of you want to get 30 minutes a day, whether that's 2 15-minute sessions or 3 10-minute sessions, however you want to break it down, but 30 minutes, 5 days a week. So like 150 hours of movement, of cardiovascular movement. And then integrating ways to strengthen the hips, whether it's through doing any kind of squatting, these are very general, but PT is very individualized, but strengthening like the glute max, you can do squats, they can do modified bridges, they can do things that are like in quadruped, so hands and knees, and then kickbacks, like lifting up the hips. That's a good exercise for the outer glute, the glute med. I'll have patients do things like sidestepping with maybe a band, a little resistance band to start strengthening the outer hip area. And there's other different things, but even things like single leg balance, like that's another good task that will load the hip and get and the glute med to really have stabilize in addition to the core. And there's a lot of core strengthening exercises out there, but I like to do a lot of things in quadruped. So when the person is on their hands and knees, and then the baby, as the baby grows, is like the resistance. So they have to do what I call like baby huggers, and they'll draw their belly button up and in like they're hugging their baby with their abdominals. Maintain that nice position of their spine where it's neutral, and then challenge themselves with like opposite arm, opposite leg reaches, or just the legs, just the arms, and then doing that with breath. So incorporating the breathing so we can add pelvic floor as they engage their deep abdominals. They can contract their pelvic floor muscles as they breathe out, and again, work on stability that way. For my patients who have toddlers, this is hard to do because then they're going to have their toddlers like climbing all over them during those days. So I usually keep it functional for them. And I'll say, every time you lift your toddler, every time you have to bring your toddler out of their car seat or out of their high chair or any kind of transitional movement, I want you to do that abdominal brace where you engage your deep abdominals, contract your pelvic floor, and then use your legs. So teaching them how to just make it part of their daily activities, that's a good way to strengthen, especially when time is maybe a little more limited to focus on doing a whole exercise program.
Yeah. I love that. I love the idea of empowering patients to use their own bodies, use their baby as a resistance, utilize, being mindful of their time, because yes, a lot of my second, third time moms have toddlers running amok, and just understanding that there's so much that you can do on your own accord. But there also are times where, again, as we already alluded to, that pelvic physical therapists are very much needed. What are some warning signs that a pregnant person should watch out for that might give them an indication that they do have a pelvic floor issue and that they should talk to their OB about a referral?
Yeah. So typically, if the patient is experiencing any kind of bladder or bowel dysfunction as it relates, nothing new in a sense of sudden onset, but, relating to like as their pregnancy progresses or as they are lifting, bending, doing some more activities that might load their pelvic floor muscles. That's one thing. If you start to feel even the inkling of pressure, some people will say, oh, I feel a little more pelvic pressure. That might indicate that we need to work on that pelvic floor muscle endurance, strength, or coordination. Any pain with penetrative touch, or pain or difficulty with evacuation, especially with bowel movements. There's that phase where you can get constipated during pregnancy. And oftentimes they're like having to strain really hard. And some of it, we can help with posture, teaching toileting posturing and use of the breath and how to focus on relaxing the pelvic floor. So those might be signs. Of course, I collaborate with the team of providers all the time if there's a patient who comes in what we call direct access, so without a referral, because I want to make sure, one, nothing else is going on. You're the experts to make sure that everything's okay in regards to the baby's health and the mother's health, and then I'm able to do my scope within that musculoskeletal system or neuromuscular skeletal system. But I also know there's things that we have to differentially diagnose that I need to collaborate with OBGYNs like yourself to make sure I'm not missing anything that is non-musculoskeletal in nature. So I think it comes both ways. I know the things that I know what I know, but I have to definitely collaborate with you and providers like you, because if there's something else that could be causing it, I don't want to miss that either.
Yeah, of course. I always say this. I think I was drawn to medicine because I grew up playing sports and I love the concept of team. And I think to care for people in the way that they deserve, it's not one solo practitioner, it's a whole team. And so I love the idea of working in collaboration with my local pelvic PTs. I wish Eileen lived in the Bay too, because we could work together. But I love working in collaboration with my pelvic PTs and my lactation specialists and everyone in the community that kind of helps support pregnant and postpartum women. So I'm glad that you feel the feeling is mutual, I'd say.
Yes, of course.
And then thinking about that first appointment for a pregnant person going to see you, I've come to realize that most patients, when they're pregnant, because they're for the most part young and relatively healthy, haven't really accessed healthcare in the same way that they do in pregnancy, right? You go from maybe seeing someone every couple of years for your pap smear to seeing someone, almost monthly for your pregnancy care. And then new things do arise, right? I think pregnancy can be a scary time for people who otherwise never had any problems to suddenly be like, wait, I have this pain. Is that normal or not? Or man, I'm leaking urine now. What's happening to my body? And there's this fear that's built with that. And some of that fear is just because of the unknown. So as we kind of try to brace ourselves or minimize that fear of the unknown as much as possible, what would a patient or a client expect for the first consultation with you or any pelvic PT? What does that first appointment entail, and what would they?
So it's probably going to vary a little bit practitioner to practitioner, but I can speak from our practice. So the first visit is usually an hour, and so we have a whole hour devoted to that evaluation. We'll go through the patient's history, and that will entail not just their reproductive health history, but looking at the things that are aggravating them. So prioritizing whether they're having more pelvic girdle pain or hip pain, or it's just incontinence, finding out from the patient's perspective what they view as the top priority of areas they need to work on. And then I'll ask questions regarding their bladder health, bowel health, and then in general activity participation. So what are the things that are limited because of their symptoms, or what is it aggravating or easing factors, so I can better understand the nature of their symptoms.
Mm-hmm. Mm-hmm.
We'll go through previous pregnancy history, any other birth-related trauma history, so I have a better understanding of where they're coming from, even any other underlying injuries. If they have had hip pain, knee pain, low back pain previously, that's also another risk factor to any kind of pelvic girdle pain during pregnancy. And then go through the things that they want to do. So kind of understand what they want to maintain doing, what are the things they have to keep doing at home, like the toddler, for instance, they kind of paint a picture of what their life is like. So I can cater their program to keep doing those things or improve their quality of life in those ways. Then we do our musculoskeletal exam. So that's going to be looking at posture, looking at how they move. So we might do a little movement analysis where, say they're saying I have pain when I roll from side to side in bed. So I'll say, okay, show me how you're doing that, or when they have pain when they bend down to pick something up. So very functional movement analysis, as well as looking at, we call like a gait analysis. So having them walk and seeing how they walk. And that gives us an idea, like all the way from the torso to the hips, to the knees, to the feet, and gives us an idea of how all the muscles are working together or maybe need to work better to provide stability and support.
Yeah.
Yeah. So, and then palpation, there's a whole lot of things, but say someone had pelvic girdle pain, I may go further in and palpate along the pelvis, the bony pelvis, the musculoskeletal components that lead up to the pelvis. And then if they have pelvic floor issues too, or if they're having incontinence, I may look at externally their pelvic floor muscle function and how well they can isolate their pelvic floor, and that performance of range of motion. Can they contract? Can they relax? Do they have good endurance? So there's a lot that we squeeze in.
It's
a lot.
It should be fully comprehensive, right? That they're going to you for your expert analysis of their pelvic floor. So I appreciate that. And it's funny that you said, part of your assessment is watching the gait, watching how people walk. I like to play a game with myself when I'm just out and about. I see pregnant people and I try to guess based on their belly size, like how many weeks they are. So now I'm just imagining Eileen be at Whole Foods and just watching people and be like their gait's off this and their gait's like this. Like, do you find yourself in real life just watching how people walk and making an analysis? You can't turn that part off.
You can't. No, it's like, I think every PT has that innate tendency to analyze people's walking without knowing they're not trying to, but we can't help but notice, or I can't help but notice.
Yeah. And I wonder, just on a quick personal note, I think, you have two beautiful daughters. I'm assuming they're beautiful because you're beautiful. You are a wealth of pelvic floor knowledge. How did you apply that to yourself when you were pregnant and when you had your children? Was that something that was ingrained in how you approached your pregnancies?
Yeah, I definitely was preventative all the way. I was trying, at least I'll speak for my first, because, it's like you have more time, I feel. And I was definitely all about strengthening and making sure I was working on my pelvic floor muscles, working on my stability, working on my core, staying fit, really working on my cardiovascular health. So I was really about prevention. And then after I had my daughter, my first one, I saw my colleague. So I said, you know what, I'm going to practice what I preach, and I'm going to go see my colleague, because I want to take care of myself. And two, I can't be the pelvic floor PT leaking and treating patients for incontinence. So I said, I need to get help too. Yes. So
that's
shout out to Amy Diaz.
Yeah. Shout out to you, Amy. No, but it's true. And also, I think, and I actually appreciate you saying that. I think that as healthcare providers ourselves, because our jobs are to care for others, all day, every day, sometimes we forget about ourselves. And so I love that and especially when you have a newborn, you were hecka busy. So I love that you made time for yourself. And we definitely will talk more about postpartum care. Before we get there, I think something that you said earlier that I really want to spend a little bit more time elaborating on is preparing the pelvic floor for actually like giving birth, right? We talked
Yeah.
about preventative care at the beginning of pregnancy and stabilization, et cetera. But I think a lot of patients, I mean, their favorite questions to ask me are like, how can I be a good pusher? Like, what can I do to reduce my tears? Like, is there anything I need to do to help my pelvic floor, be able to have a successful vaginal delivery?
Yeah.
Knowing that there's many ways to have a baby. I was born via C-section. There's nothing wrong with being born abdominally either. But, I think those are very common questions that patients ask me. I'm sure clients ask you as well. What are some of your tactics for preparing for childbirth?
Yeah, so I love that phase, honestly. So come 34 weeks, I tell my patients, at 34 weeks, as long as there's no high risk or contraindications, we're going to start doing perineal massage, and we're going to start working on the mobility of your pelvic floor. I always tell them they can bring their partners in. It's hard for you to do it on yourself. So I always invite the partner. I say, bring your partner, make sure they trim their nails. We're going to teach them how to help you. Or there's lots of tools now. There's a lot of self pelvic floor massage tools as well.
Yeah.
So either they buy that, and I also teach them how to use that. But come 34 weeks, we start focusing on pelvic floor muscle awareness training, teaching them how to breathe, how to relax the pelvic floor, how to coordinate their breath with pushing so that they're not straining and pushing with a strain, but more so elongating the pelvic floor. And then working on shifting our program from a lot of strengthening and stability. They're still working on that in some way with functional movements, but we focus then on the relaxation component. Like if they have tightness in their hips, their glutes, their inner thighs, their legs, their lower extremities, I want to make sure we stretch and we help them so that they can relax their muscles around the pelvis and their pelvic floor while knowing how to use their breath and knowing how to coordinate their pelvic floor muscles to elongate and push. So we do a lot of preparation, and usually I'll get a window of 34, 35, 36, 37 weeks. So around 37 to 38 weeks, they've gained the tools, and then I want them just to like prepare and relax and be at home.
Yeah.
Some patients come in till the very end. They're like, no, I really need, like maybe they have a lot of pain. So I'll see them till their due date, till they're ready.
Yeah. Yeah.
But yeah, typically that last 34 to 37 weeks, we focus on just pelvic floor and mobility of the perineum, awareness. I'll use a camera and they will see their vulva and how their muscles move. And like you said, it's very empowering because then one, they know how they're aware of their muscles, they feel it, and they know how to do the action of when they say push, how do I do that? Where do I go? Where does my brain go? So it's really cool to see it. And it's a way to improve their outcomes of, if they want to try for a vaginal delivery, help improve their ability to push without straining.
Yeah, no, it's true because it's not until for most women, as obviously our first time moms, because I've never tried to have a vaginal birth, it's not until you actually are at that stage pushing for the first time in your whole life that you're trying to coordinate it. And, I always, and I say this truthfully, part of my job, what makes it really hard is I have 10-minute appointments per person and I'm trying to cover as much as I can and what I need to, but I can't have a whole, month-long tutorial of how to push and like relaxing your pelvic muscles, et cetera. And so one of the goals of this podcast is to bring that information out there because I know that I myself can't give that information to everyone at all moments. And so I'm so grateful that we're already having this conversation. But it's also, I also am thinking about, and I'd love to spend more time. You talked about perineal massage. We talk about it a lot. So when patients ask us like evidence-based to reduce risk of tearing, like the strongest evidence is with perineal massage. I know that this podcast is going to be heard by people, but some people are also going to watch. Can you describe as best as you can and also utilizing, your hands to show kind of where the perineal massage should be? Where is it in
Yeah.
the perineum? Or, besides fingers, is there anything else that people should utilize? Should they be using oils, lotions, anything else that you advise?
Yeah. So the first thing we start with is breathing. So breathing and getting that breath to help move your pelvic floor. So diaphragmatic breathing. And then we have a camera at clinic, but you can use like a hand mirror. But I'll tell patients, okay, I want you to use the mirror and I want you to look at your vulva. So they can see everything from the vagina, the perineal body, the anal sphincter. Everything is within view. And I say, okay, I want you to take a deep breath in as best as you can. It's kind of hard to take a deep breath, but imagine sending the breath down to your pelvis. And as they inhale, the pelvic floor muscles will lengthen, or they might see their perineum kind of push out or descend. We call it like kind of elongate or descend. And they may see the opening of the vagina also open a little more, or the anal sphincter soften, get softer or open as well. If they have like really good movement in their muscles. We see quite a few patients who are high tone. So their muscles do not move. They're non-relaxing oftentimes. They're just very tense because there's so much tone or tension going on. So those are the patients that I'll start teaching them how to do massage just along those perineal muscles. So one of the muscles we do is superficial and deep transverse perineal muscle. In the center where my fingers meet, we imagine like the perineal body. And then where my fists are, we think of our ischial tuberosities or our sit bones. So that muscle spans from the perineal body all the way to the sit bone. So they might start with their fingers going across. So if that muscle, it's like a transverse or horizontal muscle. I might have them start by stroking downward along those muscles, helping soften, and they might feel resistance under their fingers. So they can do little circles and just making that muscle have more movement because it's going to help us with everything coming down.
Yeah.
And then there's two sets of muscles right around the opening of the vagina, and we'll work on those too. So we have the bulbar cavernosus and then the ischial cavernosus. Bulbar cavernosus, oftentimes there's a little more tension right at the bottom third, especially close to the perineal body and the opening of the vagina. So I'll have them do the same thing and massage or circles, however they feel is comfortable for their hands, but soften and get some soft tissue mobility, improve that soft tissue mobility. So we start just externally. And then you can either use, a lot of patients already have like a water-based lubricant at home, but if they have something more like any kind of non-fragranced oil, natural oil, olive oil, coconut oil, they'll use a little bit of that. And then if this is the very bottom of the vagina, the vaginal opening, I'll have them, there's two layers. We'll go to the first layer, which is like to the first line of the finger, and we'll massage along, if you think of a clock, like 3 o'clock to 9 o'clock, 3 o'clock
that's a perfect analogy.
To 9 o'clock. And focusing on both sides feeling like symmetrical, soft. And sometimes I'll just start off with quadrants. So I'll say, okay, stretch along 3 o'clock, stretch along 5 o'clock, 6 o'clock, 7, and 9. And each one they'll do with like deep breathing or with their partner and try to imagine softening those muscles. Because oftentimes if it's really a high tone pelvic floor, this movement of the stroking can be a little painful or irritating. So sometimes I'll just do more of a sustain, hold, stretch. And then we'll do the deeper layer, going to the second layer of muscle. So we had the first muscle, I'm going to name them so everyone knows the names of these muscles, but pubococcygeus,
that's great.
And then iliococcygeus. Iliococcygeus is going to be the next layer. And we'll do the same 3 o'clock to 9 o'clock or even 5 o'clock to 7 o'clock, depending on, again, it's very individualized. Wherever the patient has tension, we're going to focus on. But again, the goal is to help us to kind of go from here being like more of a closed,
tight
tension, pelvic floor to more of a open and more relaxed muscle with more range. We call it range of motion to lengthen.
Yeah.
Then we may practice actually with the mirror. Again, a lot of visual feedback is helpful. And it's kind of a nice setting in the clinic because it's like they can really just focus on they can look and see what's happening in real time. at home, it's hard to get that kind of set up in your bed. So we do that, and I'll have them contract, relax, push. And we won't just practice that laying on their back. We'll practice it in side lying. We'll practice it in quadruped. In clinic, we have some really nice little different modalities like biofeedback. And so I could use biofeedback, surface electrodes to give them like a visual display of the electrical activity of their muscles. And then same thing, go through different birthing postures and see, can they like maintain a relaxed pelvic floor and push in those postures and keep the pelvic floor muscles relaxed. So there's so many ways we can teach or, help encourage awareness and teach them how to coordinate their muscles, depending on what kind of learner they are. But it's a lot of hands-on. Sometimes, some patients love hands-on cues, like tactile cues. Some patients love the visual, and some patients are just like good with verbal. So it just depends on how they learn, but we want to teach them. Yeah. We want to give them the tools.
No, I think that's great. I mean, again, I've probably said this before, but I do this podcast also selfishly because I get to learn so much. I'm a clinician who refers my patients to pelvic PT, but I myself never gone. And so I have no idea what happens, once my patients get to you. And I love learning the full breadth of what they get to learn.
Thank
and to
you.
some extent, I wonder, there's a lot, I've been reading a lot of recent review articles talking about how long, moms push for the first baby versus the second baby. And there's a lot of factors for that. But some of it for me is understanding that for a lot of first time moms, because again, you've never pushed before. Sometimes that first hour of pushing is really just you figuring it out, right?
Yeah.
We're all figuring it out.
Yeah.
And so now there's a part of me that thinks like, man, if I sent all of my patients to pelvic PTs, maybe they wouldn't even like waste time with that first hour of pushing because they would come from Eileen and be like, oh, no, we already know how to do this. We've got this.
You're too generous. Yeah, you're too kind. No, I feel like everyone's different. I feel like the patients, I just had a new mom come back this past week after she had her baby. And she was she texted me. She was like, Eileen, I didn't tear. I pushed and I did it the way you taught me. And she said, like, I love this patient too. She's like, I told the nurses, I know how to do this really well. So get ready. Or she told her something. She told me the way she said it was just so like, it made me so happy. And I was so happy for her that she had such a positive experience. Like that to me, I'm just like, if I can give you the tools, it's not me doing it, it's them because they're the ones learning it. I'm just one of the people helping them. And that's like the reward, you just want everyone to have, because I mean, you too, you probably there's a lot of patients who like don't have that experience, So it's and like you said, there's multiple factors that lead to that. But if we can, whatever we can do to help, it's such a great feeling.
Yeah, no, what you do facilitating women in terms of, giving themselves the birth story that they want, let alone making them feel strong in their bodies. That truly is such a rewarding experience for you as the clinician. I love that she was so enthused by her experience that she took the time to even text you about it. That makes me so happy. So I'd like to take a moment to tell you this is my passion project based on years of experience as an OB/GYN doctor. I aim to empower moms and moms-to-be and those in the pregnancy and postpartum care space. If you appreciate what I do, please take a moment to like, subscribe, and share with your friends so it can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, suggestions, or questions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. And that's a great segue because she is now a new mom. And I'd love to talk about our new moms, to talk about kind of postpartum. So we talked about, again, beginning of pregnancy, preventative care, towards end of pregnancy, preparing for birth. After having birth, that's probably for me as a clinician when I tend to make most of my pelvic physical therapy referrals, because birthing the baby changes the pelvic floor in such a big way. Can you kind of describe from your expertise how the pelvic floor changes after giving birth? And we'll go from there.
Yeah. So there could, depending on the birth story, there can be lots of changes or not too many, but, we look at the patients who like have had any kind of tearing or prolonged labor, even not even just like a really prolonged period of pushing or even just getting to that point. There's definitely a lot that can change, even from pelvic congestion. So we'll see if I see patients within the first like 4 to 6 weeks before they're cleared for pelvic floor work, I'll just do things like MLD, manual lymphatic drainage, because there's a lot of fluid and swelling and things are still healing. We'll start that. And even abdominals, there's a lot of abdominal weakness, muscle inhibition, which means like, because everything was so stretched and not used the same way, the muscles are weaker. They can't fire as quickly. So we work on initiating that program of how do you find your core muscles again, especially if it was to the point where they had like a big separation of their abdominal muscles.
Yeah.
Helping them with that. Postpartum is a hard period because, like you said, they're juggling a lot of things. They're sleep deprived, most likely. Coming into clinic, I always invite the babies. Say you can always bring your babies. They're always welcome. Because sometimes it's hard to get out of the house with your baby, but I always encourage that. But sometimes they just want to come and have that time for themselves. So however it works, but it's a challenge, and it's definitely a privilege in our society to get postpartum care in that way. So I try to make as much of the time, useful, and I'll try to build a program. So we'll do a lot of the hands-on work, whether it's working on scar mobility or working on trying to teach them again how to activate their pelvic floor or their abdominal muscles or their low back muscles, giving them a program that they can do that's realistic. And then prevention. So if they're having incontinence or they're having prolapse, teaching them like preventative measures. So every time you lift, every time you carry, I want you to breathe out and I want you to engage your pelvic floor or your deep abdominals. Or every time you hold your baby and you're patting them or after you're burping them, there's a lot of repetitive orthopedic issues we see in PT from postpartum moms. So there's like Decker vein syndrome. There's like a lot of tendonitis in the wrists, lots of like overuse and lots of postural changes and overuse. So we'll do like preventative stuff. I give them like after you nurse or after you feed the baby, we're going to do 5 of these. I call them like PT snacks. So they have their snack after they do something that they're already doing, like feeding the baby, or they do some scapular depression retraction, like kind of squeezing their shoulder blades back in together so they can fit it in. Because it's hard to remember I need to do my PT program now. But if they can take a PT snack right after they feed the baby, that's like a nice way to incorporate. Or they do like their stretches right after they feed their baby or change a diaper. That's a nice way. And then if they bring their baby in, it's bonus.
I'll just interrupt. Sorry,
please.
Because you're showing things that people who are listening might not be able to see. So can you describe the PT snacks that you just showed me? So it sounds like these are some upper body work. So there's one where you're bringing your arms out to the side. Do you want to just describe them in case people can't see?
So I call these touchdowns. So if you imagine your arms like touchdown goals, the elbows and the wrists are kind of like at a 90-degree angle, like shoulder height. Yeah. And then I have them squeeze their shoulder blades down and back. And it should feel like really good, especially after being in that forward flex posture. Yeah, it should feel like that feels like, because they're stretching out their pecs, the front of their chest, which is always like kind of closed. And then they're strengthening their like scapular muscles to help stabilize and improve their posture. So it like kind of resets them back up. That's one. I was doing some wrist stretching too. So there's different ones where you bring your hands together like you're praying, and then you stretch downward. And that's one. And then there's a reverse prayer. So you flip it upside down and you're like, ooh, you feel a really big stretch in the front of the wrist as well. In addition to just the basic kind of, if you have your arms straight, pull back on your fingers, but things that are going to help prevent those tendons from getting too tight or overused or inflamed, kind of helping with that. So there's a lot of preventative measures.
Yeah.
But
no, you're right. Like,
there's so many things.
When you're with a newborn, it's so natural that they are your primary focus, because that newborn is very
Mm-hmm.
appropriately very needy because they're
Yeah.
newborn, they're brand new. And so you suddenly, rather than, sitting up and having like proper posture that we've all kind of tried to train ourselves to do, you're just tired and you're kind of slouched on the couch and you're holding your baby all the time and you're doing all these things again and again. Like I
Mm-hmm.
liked you were showing, like, burping the baby. Like there's just things you just do again and again. And so it's just like, I like that the concept of PT snacks of like, okay, well, I have, the baby's down for maybe 30 minutes. Like I have time to like get in a little PT snack before I do, clean the bottles and rinse the pump and all that stuff. So sneaking it in.
Yeah.
Do you have any good PT snacks for the pelvic floor? Like things that moms can do when they're doing exercises at home?
Yeah. So there's lots of different needs, I guess, like depending on what's going on. But say there's just lack of endurance of muscles. So oftentimes I'll have patients, again, you have to make it real, like doable. So after you urinate, after you've emptied your bladder, that's probably you're already like done. You don't want to do Kegels when you're peeing, because that's going to mess up the whole, like, you're supposed to empty, but like say they've emptied completely. And then, as you know, sometimes patients feel, again, this is like when the bladder's the emptiest or should be lightest, they feel like they can contract their pelvic floors a little bit better. So not for everybody, but especially for the person who may not feel those muscles, but after they've voided and they wash their hands, they're sitting again, right after they've urinated, use their muscles. So they start to contract and relax, hold it for 5 to 10 seconds, relax the muscles. And then honestly, to build resistance, the fuller the bladder is when you do your pelvic floor contraction, that's again, more load, more resistance on the pelvic floor. So immediately postpartum, I'll usually say, okay, after you urinate and you're done washing your hands, you're sitting, you're doing the next thing, let's just like use that time to cue you to do some of your exercises, do some of your pelvic floor exercises. And then after that, I'll start to load it, whether that looks like they're going, they're doing it when their bladder's partially full, or they're doing it maybe not right before they have to urinate, because again, we want them to empty, but they're waiting more time, like the interval between their last void and doing their Kegels, their pelvic floor contractions, is a little longer.
Yeah.
Some patients use vaginal trainers or vaginal weights. Those are a little harder to use, but one way, I've had patients do this when they're at home, when they're, they have the time to shower, put their weight in and have their pelvic floor weight in as they shower. So it's like you're 2 for 1, and you can clean it after.
Yeah.
And you've worked on your like endurance. Or if they're brushing their teeth, like same thing. They don't have to use a weight, but they can think about contracting their pelvic floor muscles on and off. Relaxing, of course, is important, but making sure they can work on endurance that way during that task. But I like to tie it to something they're already doing. Otherwise, it's hard to stay like on top of it. It's hard to stay compliant. Like, did I do it? But if you're like, I have to brush my teeth. Oh yeah, Eileen wanted me to do my pelvic floor exercises when I did this, or after I urinated. So, and I do the same for my birthing people who have had cesareans. I'll say the same thing. I'll say, I want you to work on your desensitizations. They're going to do like I call smiles along, above and below their scar. They're going to work on stretching and getting tissue to move above and below their scar once, again, everything is closed and healed. Yeah. And then they're going to work on different textures. So that can help reduce that like sensitivity or the numbness that they have around their scar. And then that in turn can help them build their core strength, because then they can feel more as well.
So going back to, you said so many golden things, so many things I want to like be able to go back and touch on. So one is just acknowledging that, yes, when you're postpartum, whether it's baby number 1, 2, or 3 or more, you're really busy. And sometimes you lose track of time and lose track of tasks. And so I love the idea of just corresponding the exercise you're doing at home, like your Kegels, with something that you're already doing, whether it's showering or brushing your teeth. And then something else that you started to talk about, because we talked about a lot about the pelvic floor as it relates to vaginal deliveries as well. But yes, we care for a lot of moms who've had cesarean births, abdominal births. And so, so you were talking about, one process you're talking about was desensitization. Do you mind describing that more? So it's putting your hands on your own abdomen above and below the incision. Yeah. Do you want to describe that?
Yeah. So early on, it may be too early to touch the scar. So I usually do peri-scar. So that's like one finger underneath and one finger above the scar. And then I call them smiles because you're kind of making a smile. You're kind of going from the center and then stroking up. And it's very light touch first. And then you can start to build a little bit more stretch. And then we progress to doing like circles. Same thing. I just want to get the tissue surrounding that scar to be able to move, slide and glide and not be so numb, or some people it's hypersensitive. And so that prevents them from touching it. My sister just had a baby.
Yeah.
My nephew's 4 months old and she tried so hard for a vaginal birth and ended up having an emergency cesarean. So she expressed to me, I don't think she'll mind me sharing, but yeah, she doesn't, it's hard to touch that area. It's very sensitive. Maybe there's some trauma even tied to it. So taking it in a process that is going to be doable for the mother, for the birthing person is going to be important. So for her, it was just like light strokes, then a tissue or a cotton ball, something that's texturized to help restore her sense, like help her nervous system, her nerves know, hey, this is a safe touch and it's okay, and then going to more texturized fabric so that, again, not everything is seen as noxious or meaning like, it's like, ooh, that's like a really bad feeling, or that's like there's some altered sensation, definitely, but it starts to get your body used to that feeling. And then it minimizes that feeling of being so sensitive or being so like, ooh, that's a little, I don't like that, it gets the body acclimated. It's like a little bit of exposure therapy to touch.
Yeah. Yeah. That's really smart, and something that I literally just learned from you now. And I love that, to be able to bring that to my C-section patients, because you hear a lot about scar massage, right? But not in the context of also just helping retrain the nerves with different textures. And I really like that concept, because there's some patients who they still feel really numb because the nerves haven't grown back. But you're right. There's some patients who have on that spectrum feel a lot of sensitization. There you go. That's the word. Hypersensitivity to the nerves. And so kind of being able to gently acclimate them to touch can go a long way.
Yeah.
Something that also is very much a hot topic, whether you have a vaginal birth or abdominal birth, is that diastasis recti. Do you mind kind of defining for patients what diastasis recti is, and kind of your approach as a physical therapist in terms of improvement? Yeah.
So diastasis recti is going to be really, so there's two parts to it. There's the rectus abdominis muscles, or what we call like our 6-pack muscles. And we have connective tissue between them. That is our linea alba. They call that the linea alba, but it's basically connective tissue. And during pregnancy, that stretches, and that can be to accommodate the growing baby. So with that, if there's a lot of stretch and growth, that connective tissue has to do the same. It has to stretch. So that can make the distance between the rectus abdominis a little larger. And there's different parts that we measure. There's like the umbilical layer, the belly button. There's like 3 or 4 centimeters above the belly button, and then same thing beneath. So we check different points along that whole linea alba, that connective tissue, for separation. And the way I explain to my patients is connective tissue, once stretched, we can't change. Or plastic surgery can change that, but PTs, we can't change the connective tissue. But we can change your muscle function. We can improve the muscle coordination, the use of your breath and pressure systems in the abdomen to help keep things supported and to prevent things from getting larger. Because honestly, diastasis recti affects people who've never had babies, men even, and definitely like postpartum. So I tell them, just so they have the realistic expectation of, you know what, this may not be like before where it's together, connective tissue, once it's stretched, I can't unstretch it. Unfortunately, I can't bring it together. So I say, but we can improve your muscle function. And so we start at the deepest layer of the abdominals to the transversus abdominis muscle. Get that layer working, get that layer coordinated, get that muscle stronger and having better coordination with all the things they have to do so that there's like the deepest support. And then we get the internal obliques, the external obliques, and then lastly, the rectus abdominis muscle. So it's like layer by layer training. Then more importantly, integrating it into things that might increase that interrecti or that muscle distance. So like straining, preventing them from, teaching them how not to strain when they have to lift something or when they have a bowel movement, preventing those kind of possible aggravating factors. So they're aware. And then it's scary. Yeah, it's definitely scary to feel. But then they're aware of, okay, this is what is happening in my body. And this is how I can prevent it from getting worse and how I can strengthen my muscle. So like you said, it can dissipate a lot of fear and anxiety around the change that has happened in their body.
Yeah, so well said. And I like the description of working like layer by layer, right? That I think there's this misconception of like the snapback, right? Like I think about these famous people. I'll use the Kardashians, for example, but like people always just like 3 months post baby and like there's a picture of them like looking snatched, but that's not real life. And I think that oftentimes women are like, my baby's out of my body. Where's my belly? When am I going to get my belly back? And like, it's hard to describe to women and birthing persons that, hey, you did something incredibly beautiful and physical, and it will take time for your body to kind of adapt to that change, but it also won't necessarily look exactly the way that it did before. And a prior guest said this, and I love this terminology, and that's the way I'm going to continue to reframe it. It's an evolution, right? Evolution means something that is changing, and it's not necessarily a change for the worse. It's a change for like a new normal, if you will. But I love what you're doing, and what you're reminding patients is that, there's ways to still strengthen your body, even if you can't repair the connective tissue. That part's been stretched, but there's ways to strengthen your body from inside out that can make a big difference. What are some of those exercises, again, that maybe you teach clients in your session, but they can do at home?
Yeah. So one of the very basic ones we do is, if they're laying on their back and their knees are bent, and we have them take a nice deep breath in, teaching them how to get the deepest layer of abdominal muscles. They kind of have to like exhale and draw their belly button, their navel towards their spine, or even think about the hip bones, the very front of your hip bones. Think about those coming together. So that's where that muscle runs. That muscle runs deep into the pelvis. And it goes actually all the way to the spine. It attaches from the front of the deepest abdominal area all the way to our lumbar spine. And so I think about like putting their hands. So if they're listening, they could find their hip bones in the front, putting their hands right on those bony prominence, the very two hip bones, and then going slightly inside of those hip bones. And that's where you're going to try to feel a little bit of muscle tension as they contract. So then they take a deep breath in. As they exhale, they think about drawing their navel all the way back and towards their spine, like kind of deflating as they breathe out. And then the hip bones coming together. And if they do that, those three things, like exhale, draw the belly button down towards the back, and bring the hip bones together, they might feel a muscle kind of pop into their fingers, right where their fingers were inside of the hip bone. And that's how, or one way that we can try to bring awareness to like those deeper layers, because it's not like a crunch. Crunch is like the most superficial layer of muscle. Yeah. It's really trying to get those deeper muscles. And if they add a Kegel to a pelvic floor contraction to it, even better. That can get those deeper layers to contract first. And then we integrate that into all different movements like marches or dead bugs or bridges. But it starts with that movement first, and then adding a little bit of the other hip movements to it.
Working your way up. No, that's great. I think oftentimes patients will ask me as well, like, wait, are there exercises I shouldn't do? Are there exercises that can make it worse? And I think you alluded to, of trying to avoid habits that make us strain, but are there specific exercises that they shouldn't do within the first couple of months of postpartum that actually tend to kind of push the muscles out rather than bringing them in?
Yeah, I think so. I have a hard time telling patients not to ever do anything, because Like, for
Yeah.
instance, there was a lot when I first graduated, I learned to tell patients never to do a sit up after they had a baby. And we know now, we sit up every day we get out of a sofa. Every time we get out of a deep chair or get out from like a soft bed or sofa, that's a sit up. We have to do that. So there's no way I can tell patients never do a sit up. But we can say, if you're doing that movement, I want you to exhale and I want you to brace your abdominals with it. I want you to think about protecting, because those muscles are not as automatic as they were before baby, and they're a little weaker. So it's like giving them the awareness of, okay, I need to actually think about engaging these muscles first, and then not hold my breath. I need to breathe out and then move into that sit up position or get up from that position. And that's going to do a lot of things to support the diastasis just by adding that postpartum.
That's great.
Exercise. I mean, there's maybe some obvious ones, like I wouldn't go. I've had patients who want to get back to like heavy lifting, and I say, let's make sure that we progress towards that first, so definitely like progressing in a realistic and timely, like a safe way to make sure they can do the heavy lifting and heavier resistance exercises postpartum is something we want to help them with, versus going straight back to what they were doing before they got pregnant or something. They're just making sure things are safe, and their muscles are ready for that load on their pelvic floor or their abdominals.
I think we're all speaking the same language. And so much what I say to patients is giving yourself grace and easing your way back into things. Like if you ran marathons prior to having your baby, no way you're running a marathon within that first 6 weeks. So you start off with like walks. And then like that walk around the block becomes like maybe a 3-mile hike becomes like your, 5-mile jog, et cetera, but you have to ease your way into it.
Yeah.
No, this is all so great. And when I think about this trajectory of our human bodies, right, we talked about this, the evolution and the way that our bodies change in pregnancy, postpartum. Can you kind of explain to those who are listening why their pelvic floor health is important, even beyond postpartum, and kind of the clientele that you might care for who are even outside of the pregnancy, postpartum field?
Yeah. Yes. Yeah. So, I mean, the pelvic floor has so many functions, but the top 4, I say, are supportive, sphincteric. So both the ability to hold back urine and stool and to relax, to evacuate it, sexual function, and stability. It is part of our core pelvic stabilization muscle groups. So as we age, as anyone ages, there's a natural course of like muscle atrophy that can occur. You throw on like hormonal changes that you're going to be helping treat too. But there's a lot of things that happen around perimenopause that affect the tissue quality and can cause vaginal atrophy. So that support system may be, again, impaired or may start to decline. So it's important for us to like any muscle in her body, we got to continue using it, and to like not just work on strength, but work on like endurance, work on coordination, really gain that nice, robust program. So not just like, a lot of people think, oh, I just need to do squeeze. But sometimes people have high tone pelvic floors, and that's not the right thing to do. They need more of like the coordination training. Or some people need more endurance. So for that prolapse, we need to have like better endurance in our muscle system, in our lumbopelvic muscles, so like our core, our back, our hips as well. And then sexual function, I have patients who are in their 80s who are still very active, and that's amazing. That's wonderful.
Get it, girl.
I know. I'm just like, wow, like that's awesome, but pelvic health is important throughout the whole lifespan. It doesn't just stop when you think you're done having intercourse, or any kind of and you're always moving. We're always moving, and we always have our bowel bladder function. So I feel like throughout the lifespan, from childhood through our last years, it's so important. And it's never too late to improve it. It's never too late.
Yes, good reminder. No, our mutual friend, my sister, said this
Yes.
earlier, and I always hold on to it. The pelvic floor is the workhorse of the body, and it's oftentimes forgotten, but it's so important for all the things that you said. It's stabilization, it's mobility, it's bladder and bowel function. Like without the pelvic floor, we'd be a hot mess. And so it deserves it deserves the respect. There's respect and attention. And I think sometimes it's forgotten, but it's conversations like this that remind not only myself, but again, anyone who gets to listen, the ways that they can engage with the pelvic floor and be preventative, and really kind of honor the pelvic floor in the way that it serves us.
Yeah.
As we wrap up our wonderful conversation, are there any like resources that you either share with your clients or recommend to whoever's listening? Because I think so much of the premise of this podcast is there's a lot on Google and TikTok and Instagram, and I want patients to be able to access vetted information, not only from the words that come out of your mouth, but ways to access that information. Any resources or tools that you would recommend?
Yeah, so I'll plug our national organization, the Academy of Pelvic Health through the American Physical Therapy Association. There's, our webpage, but there is a PT locator tool. So if you type in Academy of Pelvic Health, there's going to be a little area that you can click to say PT locator. And if you type in your zip code or city, it can give you a list of providers who are trained in pelvic health that are hopefully local to you. That's like a nice resource to have. They have a similar one through Herman and Wallace, but it's oftentimes a lot of the same practitioners. But Academy of Pelvic Health will have a way to find a pelvic floor PT that's close to you. And oftentimes they do have a lot of like for patient education. So has some, different blogs, different resources, but all evidence-based and provided through that website.
That's great.
A company that I love and I've been doing some pro bono work for, they're based out of the Pacific Northwest, Nurturely. Nurturely caters to people of color and they have a lot of scholarships. So they have robust lactation support. They have programs. They have birthing, postpartum. I do a pelvic floor component for them. Nurturely is, again, like it's an in-person platform, but they have a really strong online platform as well. And she is like the founder through a perinatal research group that I'm part of. And my colleague invited me to Kate Haven. She's like our president, I would call her, of this perinatal research group. But It connected us with all these perinatal pioneers around the nation that we want to improve, like research for women's health. Yeah. Perinatal health. Perinatal health.
Yeah.
So, Nurturely as well is a great one.
Yeah. Well, that's awesome. I'm glad that you are part of the movement of pioneers. And I'm glad that you are sharing some of those resources with us today. As we wrap things up, are there any final words of advice that you would give for either moms to be or moms, women who are already mothers who might be in the thick of it in terms of just feeling the physical changes of pregnancy, postpartum? Any final words of advice?
Yeah, I always tell my patients, if you forget everything I just said that I've taught you, just remember to breathe. Breathe through it. Breathe through everything. Breathe through your contractions. Breathe through the labor. Breathe through the pushing. Deep breaths. And then I feel like that alone keeps the body going.
Yeah.
And then secondly, you are a gem to this specialty because you're so collaborative. But I know that it's not like that for everybody. So don't be afraid to advocate for yourself and ask for that referral to PT. Sometimes you really have to ask. It's not like easy to get, but yeah, don't be afraid to advocate for yourself. And even if they say, oh, you don't need it, just even one visit it will give you so much insight into your body. I feel like even one visit is going to be helpful. So don't forget to advocate for yourselves. And it's not just for you, it's for your family. So.
Yeah, of course. Well, Eileen, I'm so grateful for you because I've truly learned so much in this episode. My mind is going back to my med school days where I used to actually literally know all the muscles in the pelvis. And you reminded me of those names that tortured me back in the day, but also just again, the knowledge that you've given me empowers me to take even better care of my patients. And I'm certain that anyone who has the honor of listening to this episode is walking away feeling so much more knowledgeable, empowered, and healthier in their bodies. So, Eileen, we are so grateful for you and your time. Thank you so much.
Thank you. Thank you so much. Thank you.
All right. Well, we're signing off for today's episode. Thanks again to Eileen Johnson for joining us.
Thank you.
Thank you very much for listening to The Golden Hour, the podcast community where moms and moms-to-be can hear stories from other mothers and learn from top experts in pregnancy and postpartum care. If you enjoyed this episode, please take a moment to like, subscribe, and share with your friends so we can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, questions, or suggestions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. Looking forward to seeing you in the next episode. Until then, stay golden.